Hi and welcome to my lecture on amenorrhea. To download my lecture deck, please go to my WordPress site, Tokina Ubigaine. Here are the references for this lecture. And this is the outline of my lecture. So first, let's review puberty development and Tanner staging. So puberty refers to the physical transitions that occur during adolescence. And adolescents also experience cognitive maturation and psychosocial maturation. The most visible changes during puberty are growth in stature and development of secondary sexual characteristics. Also noted are changes in body composition, achievement of fertility, and changes in most body systems such as the bone, the brain, and the cardiovascular system. And here's the Tanner staging. So we have Tanner staging for the breast and the pubic hair. So B1, we have prepubertal or elevation of the papilla only. For B2, we have breast budding. B3, enlargement of breast with glandular tissue without separation of breast contours. B4, secondary mound is formed by the areola. And B5, single contour of breast in the areola. B5 also means that the breast has already developed into the adult configuration. Now, for the Tanner staging involving the pubic hair, we have PH1, which is prepubertal, means no pubic hair. PH2, labial hair is present. PH3, labial hair spreads over the mons pubis. PH4, there's slight lateral spread. And PH5, the pubic hair assumes the adult configuration, which is there is a lateral spread of the pubic hair growth to the medial thighs to form that inverse triangle configuration. Now, the first sign of puberty is usually the appearance of breast budding, followed within a few months by the appearance of pubic hair. The earliest detectable secondary sexual characteristic on physical exam in most girls is the breast or areolar development, which we also call the lark. The sequence of pubertal development is as follows. We have breast budding followed by pubic hair, growth spurt, and menarche. Now, as I've already mentioned, breast budding is the earliest sign of puberty, and of course, the latest would be menarche. Then the mean interval between breast budding and menarche is about 2.3 years, plus or minus 1 year. The ratio of fat to both total body weight and the lean body weight is probably the most relevant factor that determines the time of onset of puberty and menstruation. So for adolescents who are moderately obese, have an earlier onset of menarche than non-obese adolescents. Now, in contrast, those adolescents who are malnourished, such as those with anorexia nervosa or starvation, they have delayed onset of puberty. For girls who are engaged in premenarcheal athletic training, menarche is delayed zero point 0.4 year for each year of training. So individuals who exercise strenuously should be counseled that they will usually have a delayed onset of menses, but it is not really a health problem. So they should be told that they will most likely have regular ovulatory cycles when they stop exercising or become older. The initial endocrinologic change associated with the onset of puberty is the occurrence of episodic pulses of LH occurring during sleep. Now, these pulses are absent before the onset of puberty, and after menarche, the episodic secretions of LH occur during sleep and while awake. The last endocrinologic event of puberty is activation of the positive gonadotropin response to increasing levels of estradiol, which results in the mid-cycle gonadotropic surge and ovulation. So this is a very nice diagram that shows us a model for the control of the timing of puberty. So the figure depicts the key role of kisspeptin, this one, kisspeptin signaling, in generating GnRH release. So in the juvenile state, this one on the left panel, a physiologic brake is operational. While on the pubertal stage, this one on the right panel, the brake is off. Okay, so this physiologic brake is off. So this allows for kisspeptin and GnRH release, and a fully integrated negative feedback system for testosterone in the males and estradiol in the females. So, as you can see here, there are actually multiple levels of GnRH neurosecretory control of the onset of puberty. So, as you can see here, we have the first year would be the upstream controlling genes. We also have the Kiss-15 system, and of course, the functional integration of neuronal and glial network. So, the upstream controlling genes would be this one, the OCT2, the TTF1, the EAP1, and others. And these are transcriptional regulator of subordinate genes required for cell function and cell-cell communication of neurons and glial cells, which compose a functional network. Now, the Kiss-15 system here, it directs this network, no? So, and it also connects it to the peripheral systems such as the gonads and the nutritional status. Now, some definition of terms. Now, primary amenorrhea is the absence of menses in a woman who has never menstruated by the age of 15 years. Secondary amenorrhea, on the other hand, is the absence of menses for an arbitrary period, usually longer than 6 to 12 months. And cryptomenorrhea is an anatomic disorder blocking the outflow of menses. And examples of this would be patients with imperforate hymen or a transverse vaginal septum. And here's the WHO classification for amenorrhea. So we have WHO type 1, which refers to women with low estrogen levels and low FSH and prolactin levels without central nervous system lesions. An example of this would be patients with anorexia nervosa. WHO type 2 of amenorrhea refers to a normal estrogen status with normal FSH and prolactin levels. And the classic example for this classification is PCOS. And lastly, we have WHO type 3, which refers to low estrogen levels and a high FSH level, which denotes ovarian failure. So an example here would be premature ovarian insufficiency. So first, let's discuss primary amenorrhea. So as I've already mentioned a few slides back, this is defined as the absence of menses in a woman who has never menstruated by the age of 15 years, but with breast development. Also included in this definition is patients who have no menses by the age of 13 with no breast development. Definition also includes girls who have not menstruated within 5 years of breast development. And the incidence of primary amenorrhea is less than 0.1%. Some girls with secondary sexual characteristics may present before age 15 years with amenorrhea and cyclic pelvic pain. So these are patients usually with outflow tract obstruction or what we call cryptomenorrhea. Now for primary amenorrhea, we usually classify this into 4 depending on the presence or absence of the breast with or without uterus. So first, let's discuss the first classification, which is absent breast development and uterus present. Breast development is a biomarker of ovarian estrogen production, meaning breast development is highly dependent on the levels of estrogen in a woman. So women with no breast development and a uterus present means that these women have no estrogen production or have very, very, very low levels of estrogen production. This is either the result of a primary ovarian disorder or a CNS hypothalamic pituitary abnormality, which provides the normal signal to the ovary. Failure of gonadal development is the most common cause of primary amenorrhea. Gonadal failure is most frequently caused by a chromosomal disorder or deletion of all or part of an X chromosome and rarely 17-alpha hydroxylase deficiency. Now, in place of the ovary, a band of fibrous tissue called a gonadal streak is present. So, as you can see here in this illustration, you don't see any ovaries, right? So, in place of an ovary, you have these streak gonads. Okay. So when ovarian follicles are absent, such as in patients with streak gonads, synthesis of ovarian steroids such as estradiol and inhibin does not occur. Breast development does not occur because of the very low circulating levels of estradiol. Because the negative hypothalamic pituitary action of estrogen and inhibin is not present, gonadotropin levels are markedly elevated, with FSH levels being higher than LH. Estrogen is not necessary for Mullerian duct development or Wolffian duct regression, so the internal and external genitalia are phenotypically normal female. Now, the classic example for this classification is, of course, Turner syndrome. And this is the classic features of someone with Turner syndrome. So, the karyotype for a Turner syndrome is 45X. Individuals with gonadal failure, such as those with Turner syndrome and an X chromosome abnormality, are shorter than 63 inches in height. Deletion of the entire X chromosome, such as in patients with Turner syndrome, or the short arm of the X chromosome results in short stature. Deletions of only the long arm usually do not affect height. Approximately one-third of individuals with gonadal failure have major cardiovascular or renal abnormalities. That's why for all patients that you diagnose to have Turner syndrome, you always have to look out for any possible cardiovascular or renal abnormalities. And the diagnosis of gonadal failure or hypergonadotropic hypogonadism can be established if the FSH level exceeds 30 MIU per ml. Individuals with gonadal failure should have a peripheral karyotype obtained to determine whether a Y chromosome is present. For example, in chimeric types of Turner syndrome with a karyotype of 45XO/46XY. Now, if the Y chromosome is present or signs of hyperandrogenism are present, then the gonad should be excised to prevent development of a malignancy, usually in the form of gonadoblastoma. Rarely, individuals with mosaicism, an abnormal X chromosome, or patients with pure gonadal dysgenesis 46XX, or even Turner syndrome 45X may have few follicles that develop under endogenous gonadotropin stimulation early in puberty. So, the follicles may synthesize enough estrogen to induce breast development in a few episodes of uterine bleeding. However, these women usually experience premature ovarian failure, usually before the age of 25, and very rarely ovulation and pregnancy may occur. Another example under this classification is the pure gonadal dysgenesis, either 46XX or 46XY with gonadal streaks. These individuals have normal stature and phenotype. There's absence of secondary sexual characteristics and primary amenorrhea. And some of these women have a few ovarian follicles. Sometimes they develop breast and may even menstruate spontaneously for a few years. Now, patients with 46XY karyotype is the result of an abnormal testis in utero. And this is what we call Swyer syndrome. Now, these patients with Swyer syndrome usually have female appearance and female external genitalia. They have uterus, and 30% of women develop breast. But, however, as I've already mentioned, these patients who have uterus have an XY karyotype. Another example for this classification is the 17-alpha hydroxylase deficiency with an 46XX karyotype. This is a rare gonadal cause of primary amenorrhea, and because of decreased cortisol, ACTH levels are elevated. The mineralocorticoid levels are also elevated because 17-alpha hydroxylase is not necessary for the conversion of progesterone to deoxycortisol or corticosterone. Then, there is excessive sodium retention and potassium excretion leading to hypertension and hypokalemia. Serum progesterone levels are also elevated because progesterone is not converted to cortisol. And in addition to sex steroid replacement, these individuals need cortisol administration, and they usually have cystic ovaries and viable oocytes. Another example under this classification are females with inadequate gonadotropin-releasing hormone release, or what we call hypogonadotropic hypogonadism. The basic defect here is either hypothalamic with insufficient GnRH synthesis or a CNS neurotransmitter defect resulting in inadequate GnRH synthesis, release, or both. Anosmia may also occur in some patients with gonadotropin deficiency. And usually, this is caused by a specific defect of the CAL gene, which is responsible for neuronal migration. Females with Kallmann syndrome and related forms of gonadotropic deficiency have normal height and an increase in growth of long bones, resulting in a greater wingspan to height ratio. Anosmia in Kallmann syndrome must be tested for by blinded testing of certain characteristic smells such as coffee, cocoa, or orange. Now, the next classification will be patients with breast but no uterus. Only two conditions represent this group: patients with androgen resistance or patients with congenital absence of the uterus. Let's talk about androgen resistance syndrome first. This is also called the androgen insensitivity syndrome or testicular feminization syndrome. The problem here is that there is absence of an X chromosome gene responsible for cytoplasmic or nuclear testosterone receptor function. Usually, these patients have XY karyotype with normally functioning male gonads that produce normal male levels of testosterone and dihydrotestosterone. Now, the basic problem, even if they have normal testosterone levels, is the lack of androgen receptors in target organs. And therefore, because of this lack of androgen receptors, there is lack of male differentiation of the external and internal genitalia. Now, the external genitalia remain feminine as occurs in the absence of sex steroids. The Wolffian duct development, which normally occurs as a result of testosterone stimulation, fails to take place. Because Mullerian duct regression is induced by AMH, this process occurs normally in these individuals because steroid receptors are unnecessary for the action of AMH. Usually, these patients have no female or male internal genitalia. They have normal female external genitalia and a short or absent vagina. Pubic hair and axillary hair are usually absent or scanty as a result of a lack of androgenic receptors. Now, these patients have breast development which are either normal or enhanced, even if they are XY. Now, you will ask, why do these XY women have breasts? Now, testosterone is basically responsible for inhibiting breast proliferation. Thus, with androgen resistance, the absence of androgen action allows even very low levels of estrogen to cause unabated breast stimulation. Estrogen levels here are in the normal male range and LH is slightly elevated. So in summary, patients with androgen insensitivity syndrome have normal male levels of testosterone present. However, they lack the receptors for testosterone and therefore no masculinizing effects occur. Now, the second gynecological condition under this classification is the congenital absence of the uterus, also called uterine agenesis, uterovaginal agenesis, or Mayer-Rokitansky-Kuster-Hauser syndrome. This is the second most frequent cause of primary amenorrhea, and these patients have normal ovaries with regular cyclic ovulation and normal endocrine function. And patients with MRKH have associated congenital renal abnormalities, skeletal abnormalities, and cardiac and other congenital abnormalities. Now, the next classification would be patients with amenorrhea presenting with no breast and no uterus. Usually, these patients have a male karyotype, meaning they have a karyotype of XY, elevated gonadotropin levels, and testosterone levels in the normal or below normal female range. The differential diagnosis for this phenotype includes 17-alpha hydroxylase deficiency, 1720 desmolase deficiency, and agonadism. They lack the enzyme, basically, that's necessary to synthesize sex steroids and thus have female external genitalia. Because they have testes, AMH is produced and the female internal genitalia regress. With low testosterone levels, the male internal genitalia do not develop. Insufficient estrogen is synthesized, so no breasts develop. Now, the fourth and last type would be patients with breast and with uterus. This is the second largest category of individuals with primary amenorrhea, and the most important and probably most common cause of amenorrhea in adolescent girls is anorexia nervosa. This also includes the athlete or exercise amenorrhea, among adolescent athletes, and this may also include females with genital tract obstruction presenting with cryptomenorrhea, especially those patients with imperforate hymen or transverse vaginal septum. So now let's proceed to how to evaluate patients with primary amenorrhea. Of course, when a patient comes to you with amenorrhea, whether it be primary or secondary, the rule is to rule out pregnancy first. Okay, so once you've ruled out pregnancy, then you can go on to a more thorough evaluation of her primary amenorrhea. Of course, that includes doing a thorough history and physical exam. Okay, so examine her breast, her uterus, and of course, obtain her height and weight and BMI. So as you can see here, this is a very extensive algorithm on the evaluation of primary amenorrhea. So as I've already mentioned, we have to rule out pregnancy first, no? So and do a thorough history and physical exam. For the initial lab test, we can request for the following: HCG, whether it be urine HCG or a serum HCG, just to rule out pregnancy. We can also request for FSH, TSH, and prolactin, and also pelvic ultrasound. Now, if the patient is pregnant from the result of her HCG test or pregnancy test, then you have to manage her accordingly. Now, if on physical exam and ultrasound, uterus is absent, then order for a karyotype and serum total testosterone. If her karyotype is 46XX, then she might have this condition of Mullerian agenesis or MRKH. If her karyotype is 46XY, then she might have any of these two conditions, either an androgen insensitivity syndrome or a 5-alpha reductase deficiency. Now, if she has a uterus based on ultrasound and physical exam, then check for the FSH. Is the FSH low or normal? If yes, then check for breast development. If the breast development is more than Tanner stage 2, then check for anatomic abnormality on ultrasound. Is there an outflow tract disorder? Or if there's no outflow tract or if there's no anatomic abnormality on ultrasound, then she might have a high prolactin, abnormal TSH, or high testosterone. If her breast development is less than Tanner stage 2, then you have to repeat FSH and LH. If the LH and FSH are very low, then she might have congenital GnRH deficiency, constitutional delay of puberty, or other hypothalamic pituitary disorders. If the LH is low or the FSH is normal, then she might have an hypogonadotropic hypogonadism. If the uterus is present and she has a high FSH, check for features of 17-alpha hydroxylase deficiency. If there are, then evaluate for 17-alpha hydroxylase deficiency. If she has no features of this, then order for a karyotype. And she might have any of these three conditions: a 46XX primary ovarian insufficiency, 46XY gonadal dysgenesis, or a 45X, which is a Turner syndrome. Treatment of primary amenorrhea is directed at correcting the underlying pathology if possible, helping the woman to achieve fertility, again if possible, and prevention of complications of the disease process, especially for patients with premature ovarian insufficiency or hypoestrogenism. And in these patients, we have to give estrogen to prevent osteoporosis. Now, psychological counseling, of course, is very important, particularly in patients with absent Mullerian structures such as an absent uterus, or patients who were reared as female but turns out to have an XY karyotype. Now, surgery may be required in patients with either congenital anatomic lesions or a Y chromosome material. The etiology of the primary amenorrhea will determine the type of surgical procedure required. For example, surgical correction of a vaginal outlet obstruction is necessary as soon as the diagnosis is made after menarche to allow passage of menstrual blood, and this is applicable for patients with a transverse vaginal septum or an imperforate hymen. We can also create neovagina for patients with Mullerian failure or for patients with uterovaginal agenesis but this is usually delayed until the woman is emotionally mature or already has a partner and ready to participate in the post-op care required to maintain vaginal patency. Now, for patients with XY karyotype, gonadectomy should be performed to prevent the development of gonadal neoplasia or gonadoblastoma. Gonadectomy is typically delayed until after puberty in patients with androgen insensitivity syndrome. Now, these patients have normal pubertal growth spurt and feminize at the time of expected puberty, and tumors do not usually develop until after this time. In general, women of reproductive age with hypoestrogenism, such as in the case of Turner syndrome, hormone replacement is very important to prevent bone loss, prevent the potential excess risk of premature coronary heart disease, and of course to develop their breast. And we can give a conjugated equine estrogen at a dose of 0.625 milligrams or its equivalent. Functional hypothalamic amenorrhea, such as those patients with anorexia nervosa or athlete amenorrhea, can usually be reversed by weight gain, reduction in the intensity of exercise, and or resolution of illness or emotional stress. For women who want to continue to exercise or are unable to improve their nutritional health, then we can give estrogen-progestin replacement therapy. For women with hypothalamic or pituitary dysfunction that is not reversible, such as those with congenital GnRH deficiency, then we can give exogenous gonadotropins or pulsatile GnRH. Advances in ART now make it possible for many women with primary amenorrhea to participate in reproduction. Now we go to secondary amenorrhea. Now, as a rule, we always have to rule out pregnancy first. Now, a simple pregnancy test can do this. Okay, so once you've already ruled out pregnancy, then you proceed with a more thorough evaluation of secondary amenorrhea. And of course, foremost for this will be a thorough history and physical exam. So for the history, the woman should be asked about any past medical history, risk factors, or symptoms that might suggest any of the major causes of secondary amenorrhea. Now you ask her, has there been any stress, change in weight, diet, or exercise habits, or is there any eating disorder? Also ask the patient, is she taking any drugs that might cause or be associated with amenorrhea? Is there any hirsutism, acne, and a history of irregular menses? Are there any symptoms of estrogen deficiency, including hot flashes, vaginal dryness, poor sleep, or decreased libido? Has the patient had galactorrhea, which suggests hyperprolactinemia? Or is there a history of obstetrical catastrophe, severe bleeding, dilatation and curettage, or endometritis? Now for the physical exam, so we measure the BMI because a BMI that's greater than 30 is usually observed in patients with PCOS. Women with a BMI of less than 18.5 or those who are malnourished may have functional hypothalamic amenorrhea due to an eating disorder, strenuous exercise, or a systemic illness associated with weight loss. Patients should be also examined for hirsutism, acne, striae, acanthosis nigricans, vitiligo, and easy bruisability. Breast should be examined for evidence of galactorrhea. Vulvovaginal exam should also be done and look for signs of estrogen deficiency. And of course, we have also to look for a swelling in the parotid gland and or erosion of the dental enamel, which suggests an eating disorder such as bulimia nervosa. Now, for the causes of secondary amenorrhea, we have uterine causes, and an example for this will be the Asherman syndrome, which is also called intrauterine adhesions or intrauterine synechia. We also have the CNS and hypothalamic causes, and these are the most frequent cause of secondary amenorrhea. No? So under this, we have CNS lesions such as the craniopharyngiomas, granulomatous disease, and sequela of encephalitis. We also have drugs that can cause secondary amenorrhea, such as the phenothiazine derivatives and certain antihypertensive agents. Stress and exercise can also induce secondary amenorrhea because it increases CRH that inhibits GnRH release. Weight loss, of course, is known to cause secondary amenorrhea. Now, when women lose 15% below ideal body weight, amenorrhea can occur because of CNS hypothalamic dysfunction. And when weight loss decreases below 25% of ideal body weight, pituitary gonadotropin function can also become abnormal. And also, as an example under this classification is the functional hypothalamic amenorrhea, and the normal cyclic pattern of LH pulsatility is not present in individuals with this condition. And as I've already alluded to in several slides back, PCOS, of course, can cause secondary amenorrhea. Hyperprolactinemia can also be a cause for secondary amenorrhea. And finally, we have the genetic and autoimmune causes, an example of which would be premature ovarian insufficiency. Now, this is an algorithm showing to us the diagnostic evaluation of secondary amenorrhea. So basically, like primary amenorrhea, we also request for estradiol levels, FSH, prolactin, and TSH. Now, if prolactin levels are elevated, then you have to manage her hyperprolactinemia. If estradiol levels are greater than 30 picograms per ml, then request for pelvic ultrasound. Then, if there's evidence of PCOS, request for additional labs such as testosterone and DHEAS. If there are normal ovaries on ultrasound, then patient could have a hypothalamic dysfunction. Unless, of course, there's history of drug ingestion, severe stress, exercise, or weight loss. Now, if the estradiol levels are less than 30, then look at the FSH levels. If the FSH is normal or decreased, then patient may have hypothalamic pituitary failure. If the FSH levels are high, then patient may have premature ovarian failure. Now, this is again another nice algorithm in the diagnostic evaluation of patients with secondary amenorrhea. So, as I've already mentioned, we can request for initial lab tests such as FSH, estradiol, TSH, and prolactin. We add serum total testosterone if there is evidence of hyperandrogenism. Now, if the prolactin is elevated, we just repeat prolactin levels or serum prolactin levels. And then if it's really consistently elevated, then that is consistent with hyperprolactinemia. The next step is to request for pituitary MRI to check for prolactinoma. So if the prolactin levels are normal, check for the TSH. Now, if the TSH is abnormal, then evaluate or further evaluate for thyroid dysfunction and treat the thyroid disease. If the TSH levels are normal, then check for the FSH. Is the FSH elevated? If yes, then in the setting of amenorrhea, a high FSH is typically seen with a low estradiol. Hot flashes and vaginal dryness are common symptoms, so we diagnose these patients to have primary ovarian insufficiency. If the FSH levels are not elevated, then check for the estradiol levels. Okay, so if the estradiol levels are low, then patient might have hypogonadotropic hypogonadism. Now, if the estradiol levels are not low, then look for evidence of hyperandrogenism. If there is evidence of hyperandrogenism, then your most likely diagnosis will be PCOS. If there is no evidence of hyperandrogenism, then all labs are normal and a history of uterine instrumentation, then perform progestin withdrawal test. If there is no uterine bleeding after a progestin withdrawal test, then you can add estrogen to progestin and then wait for withdrawal bleeding. If bleeding is again absent, then you can do hysteroscopy for a presumed diagnosis of intrauterine adhesions. That's it for my lecture. So in summary, we have defined primary and secondary amenorrhea. We also tackled or reviewed puberty and Tanner staging. And of course, we tackled classification, causes, evaluation, and treatment of both primary and secondary amenorrhea. Thank you for watching, and please don't forget to subscribe in my YouTube channel and my WordPress site, Doc Ina Obigaine. Thank you!